Okay, I'll just turn it on.
So I'm going to be presenting a case which we saw on the ward round yesterday. So bear with me, haven't had that long to prepare, but hopefully everyone will learn something. So first off, very importantly, Costa or Pratt? Yes. That is the result I like to see. What did you vote for, Kareem?
Well, I voted for Pret, but I drink Nescafe Gold Blend, but that option was not present. So, so
okay.
I'm one of 9 people there.
And 2 people don't drink coffee. How? Fine, right. Let me just, don't look. So.
Wait a minute. So we're still seeing Menti.
Are you?
Yeah, we are. So I'll tell you what I know you've done. If you click the share screen button again, you need to share the left-hand top one, which is your current window, because you've chosen Menti to share. We can see it's fine. Just do that again. Click share screen. There'll be a little green blob.
Okay.
And then that's it. Now we can see a medical mystery.
Yeah, fine. Okay. So a medical mystery from Afghanistan. Ooh. So the case, a 27-year-old gentleman comes into the ED with a 4-day history of feeling unwell, tired, and jaundice from this morning. So he's noticed that his sclerae are yellow. So I know that's very little information, but at this point in time, what do you think is the most likely diagnosis? And I'm just going to switch back to Menti. Can you see that?
Yeah, we can. And just go to, that's it. Perfect. So everyone will have that on their screen. So you can go back to the case, okay? And just for the latecomers, you want to just say again that introductory line. So go back, so leave that running and go back to the slide. Yeah. And just tell everyone that again, and they can all vote.
Yeah, so for any latecomers, this is a 27-year-old man who's come into the ED with a 4-day history of feeling unwell, tired, and jaundice. So what do you think is the most likely diagnosis? So I'll give it a few. 9 people have voted. Don't sit on the fence. Ben?
Izzie, Ben really wants to answer that question, but you just kind of misheard it. Could you repeat it?
What? Oh, what's the most likely diagnosis?
In a 27-year-old man who feels a bit unwell.
Unwell, very tired, and is yellow. Right, I'll give it a couple more seconds. Fine, right. Interesting. Yeah, so there's really no right or wrong here. It's just kind of to get you thinking that this is a 4-day history. So unlikely that it's going to be cancer, because it's acute, not chronic. Also, he's 27, so you'd like to hope that this wasn't pancreatic cancer. Sickle cell disease is always one to be thinking about, particularly in the right ethnic populations. However, you expect somebody to be presenting in childhood or infant babies rather than at 27. Hemolytic uremic syndrome, there's no history yet of diarrhea or further thing to suggest HUF, but it could well be HUF. I agree. I think hepatitis A and Gilbert's is probably the most likely diagnosis at this point in time, but we haven't got any further history. So great. Right, go back. So you're still clocking. You're going to take a bit more history. So yeah, 3 to 4 days of unwell, fatigue, At this point, he doesn't feel like he's going to be able to drive home because he doesn't have the strength to press the accelerator, so very fatigued. His eyes were yellow the day before he came in. He came into ED on the 1st of September, was seen by the gastro registrar, who discharged him with an outpatient blood test and an abdominal ultrasound. Can anyone pop in the chat or turn on their videos and tell me why the gastro reg wanted an abdominal ultrasound? What could he be looking for? Kareem, has anyone said anything in the chat?
Let me have a look. No, it's just me saying menti.
Fine. So we'd maybe be looking for gallstones there. So since he was discharged, he's been having night sweats, rigors, and fevers up to 38 degrees. He's a little bit itchy, but not massively, and he doesn't report any recent weight loss. So you delve further, you do a systems review. So cardiovascularly, he's had some chest pain a week ago, which resolved. He was seen in ED and told everything was normal. He hasn't had any palpitations or dizziness. So breath-wise, he feels a little bit breathless, but mainly due to fatigue. He hasn't had a cough. GI system, so he's got tummy pain, which is worse on the left-hand side. Nausea, but he hasn't vomited, and his stool is normal in both colour and consistency, and he last opened his bowels 36 hours ago. His urine is dark. He says it looks red, but he hasn't had any dysuria or frequency. He's got a mild headache, but there's no signs of any focal neurology. He doesn't report any change in vision, etc. Importantly, his past medical history is nil. Family history is nil. He doesn't have any known drug allergies. He takes no regular medications, and he hasn't started any new medications. So he is from Afghanistan. Surprise, surprise, given the title. Even though he's been in the UK for the past 11 years, and he hasn't travelled anywhere rogue because of COVID, probably. He lives with his sister and his mum. He's not currently working due to a lack of work permits. He does actually have tattoos, so sorry, that is wrong. He does, but he doesn't have any history of a blood transfusion. He denies taking any illicit drugs, though he socially smokes about once a week, and he doesn't really drink alcohol. So from what I've told you, if anyone wants to be interactive, what do you think, given his presentation, are the important negatives in the history? So this is somebody who's presented with acute jaundice. No transfusion, great. Weight loss, great, George.
Oh, that's lovely.
And then a description of the pain, maybe. Is it? He didn't have pain, did he? He didn't have any colicky pain.
He does have tummy pain. Without travel history, possibly less likely hepatitis A. Yeah, great.
It's still in the UK.
Yes.
There we are, shellfish.
Lovely, Gavin. Thank you. It's true. He could have eaten a load of prawn or something. No alcohol. Yeah. Is he a man? I don't know, but to be honest, sexual history would have been a good thing to add here. You're right. Great. Okay. Yeah, so key negative that he doesn't have any past medical history. So he doesn't have known sickle cell disease. There's no history of any autoimmune disorders, which is important. We'll come on to that later. There's no history of any malignancy or weight loss, even though he does say that he's been having these fevers and rigors. no medication history, which is particularly important here. There's no focal signs of any infection to suggest something like hepatitis A, no history of previous transfusion, and no travel history. So on examination, you do your A to E. He's talking to you, so airway's patent, chest is clear, there's no spike or lymphadenopathy. Heart sounds 1, 2, and 3. No, heart sounds 1 and 2 are present, no added sounds. His pulse is regular, he's peripherally well perfused, and there's no signs of any right-sided heart failure. So JBP isn't raised, no peripheral edema. His compos mentis, GCS 15 out of 15. On full exposure, you note that he's visibly jaundiced. His abdomen's soft, non-peritonistic, but there is some generalized tenderness throughout. And again, importantly, there's no sign of any organomegaly, so hepatomegaly or splenomegaly. OBS, everything looks pretty normal. He currently doesn't have a temperature. So
the question about farm animals, has he had any contact with farm animals?
I don't know.
Which animal do you have in mind? GD173. You can unmute.
Any contact with farm animals? Oh, pigs, hepatitis E, maybe? I don't know. Mm-hmm. I don't know, Gavin, what you were thinking there. Do you care to enlighten us? Anyway, from a hemodynamic point of view, he's stable. Oh. So you move on to some blood tests. His white cells are raised with a mild neutrophilia. He's anemic and the MCV is normal. So this is a normocytic anemia. His CRP is a little bit raised. You do some liver function tests. So his total bilirubin is 202. So that's a reference range. So that is very high. His conjugated bilirubin is 12. So that tells you that he's mainly got raised unconjugated bilirubin. Something I learned yesterday for anyone who's an F1 is that you can't order an unconjugated bilirubin. You can only order conjugated, and then you have to do the maths. All other liver function tests are normal. So ALT, ALP, GGT is all normal. Clotting is normal. And then a further non-invasive liver screen shows a raised ferritin, normal ceruloplasmin, and normal IG panel. You do a viral hepatitis screen, which is negative for Hep A, B, C, and he's also HIV negative. So if anyone wants to in fact, I've got a Menti question, hang on. Brendan, leptospira contact with rat urine if camping. Rogue, but thank you, could well be. So from this picture on the bloods, what do we think is the most likely cause of this gentleman's jaundice?
Right, come on, everyone, you've got to vote.
There's only 3 options.
Yeah, that should speed them up.
I'm hoping everyone will say the same thing for this.
Go on then.
Okay.
Yeah.
A couple more seconds. I'll wait till we get to 20, maybe. No, that's fine. Oh. Oh. Great. So nobody's put post-hepatic, which is good. Yeah, so if I go, Yeah, so this is, I think the most likely cause is prehepatic, because of this picture. So we can see when you get breakdown of red blood cells, either pathologically, so you've got destruction going on, or as normally takes place in the spleen, you get release of hemoglobin from your red cells, release of the heme, which is in the hemoglobin, which is broken down to bilirubin, and that's circulated bound to albumin. It then goes to the liver, where it's conjugated, and then conjugated bilirubin is released through the bile, biliary duct system, into the gut. So in this situation, where you've got a problem occurring prehepatically, you end up with massive overproduction of bilirubin, which overwhelms the liver conjugation system. So you end up with high unconjugated bilirubin in the circulation. And then hepatic, it could be hepatic, that would give you a mixed picture. So you'd get both raised unconjugated and conjugated bilirubin. And then if you've got a post-hepatic cause of your jaundice, so a problem down here, either due to gallstones or a malignancy, you then get raised conjugated bilirubin, because you've got, there's not a problem with your conjugation system, it's the getting the bile out of the biliary system. So yeah, prehepatic jaundice, basically the bilirubin hasn't reached the liver efficiently, or it hasn't been conjugated. So you can get massive overproduction either because of acute hemolysis or because of impaired conjugation, of which, if you cast your mind back to med school, you might remember that Gilbert syndrome is a relatively, it's not an uncommon cause of getting an isolated hyperbilirubinemia. And then the more severe form of that is Crigler-Najjar syndrome, which I'm sure no one will ever see in their lives. And then just quickly, the other forms of jaundice, your hepatic causes, so that will give you a mixed picture. And really the main three to remember are your viral hepatitis, alcoholic hepatitis, and drug causes, so paracetamol poisoning. And then your post-hepatic causes of jaundice, giving you a conjugated hyperbilirubinemia, most commonly gallstones or a neoplastic process, so pancreatic cancer. So we have, this gentleman has a unconjugated hyperbilirubinemia. What further tests can we do to prove that this is hemolysis, rather than say Gilbert syndrome? I don't have a Menti for this, so if people pop it in the chat. Blood film, yeah. What are people looking for in a blood film? LDH, great. DAT. So a DAT, yes, you'd absolutely do a DAT. That will tell you the type of hemolytic anemia you get, rather than whether you've got hemolysis. Haptoglobin, great. Reticulocytes, and yes, schistocytes, fab. So yes, you want to do you want to look at the haptoglobin level. For us, this result was pending. And haptoglobin is basically a molecule made by the liver, and it binds free hemoglobin, so it mops up all your excess hemoglobin. So in hemolysis, you would expect the haptoglobin to be low. LDH, so that's inside any cell. So whenever you've got cell breakdown, that will rise. So the LDH for this gentleman was 452, so raised to suggest perhaps he's got hemolysis. Reticulocytes, so that's because you've got increased red blood cell turnover. So your bone marrow is like ramping up to try and produce more red blood cells. So this gentleman had raised reticulocytes of 113. If you've got if the reticulocytes were low and he's anemic, you're thinking more of causes of bone marrow failure because the bone marrow isn't functioning properly. And then the HbA1c was abnormally low in this gentleman. So can anyone tell me why the HbA1c is low and what that suggests?
Do you have a number when you say abnormally low? What was it really?
So it didn't say on Sternet, it just said abnormally low. Yeah, reduced, excellent. And it suggests, yeah, Laura, great. So it suggests that this has been going on for some time, rather than it happening like for a day or something. Great. So why increase red blood cell turnover? Fantastic. So that is why if you've got sickle cell disease patients with diabetes, you can't really reliably use the HbA1c because it's abnormally low. So you've done your bloods. You might do some imaging. So I alluded to abdominal ultrasound. Is there any other imaging anyone would consider here? Given the history. Or shall I tell you?
No one's going to answer that, I don't think, without seeing it.
Nobody's going to say, fine. What are we looking for? Yeah, so this gentleman did have what we call B symptoms, so rigors, sweats, fevers, very high temperatures. So you might want to start thinking about a lymphoproliferative disorder. However, he doesn't report any recent weight loss, and he's got a history of like 3 days, so it's unlikely. He also doesn't have a history of excessive or chronic alcohol use, and importantly, according to what is it, Courvoisier's law, he has some abdominal pain, but in cases of painless jaundice, you want to be thinking about malignancies of pancreatic cancer. So we did, as per Heme recommendation, a CT cap, and we also did an abdominal ultrasound to look for gallstones. This is a gentleman, but just a quick revision of your risk factors for gallstones. So female, fat, fluids, 40, fertile. Those ones are the main risk factors for gallstone. So this is a bit of a complex slide, but really quickly it helps me think about the causes of hemolytic anemia. And I really like to split it into errors inside the cell and then errors not inside the cell. So when you think about inside the cell, things can go wrong with your hemoglobin, the enzymes, or the membrane. So the hemoglobin are your hemoglobinopathies. So that's your sickle cell disease or thalassemia, so alpha beta. There can be a problem with the enzymes or the enzyme pathways. So that's your G6P deficiency as well as PK deficiency, or the membrane can be messed up, so giving you spherocytes or elliptocytes. And then errors not inside the cell, you can split into immune causes of hemolysis and non-immune. So they're your physical or mechanical causes. The immune can be autoimmune or alloimmune, so either due to ABO incompatibility, so that's your blood transfusions, or rhesus incompatibility. And then your non-immune physical mechanical causes are all your weird and wonderful causes of MAHA, so that's your microangiopathic hemolytic anemias, as well as increased destruction because of hypersplenism. So red blood cells are normally broken down by the spleen, but in infection or autoimmune diseases, the spleen can just go into overdrive and basically destroy all your red blood cells. So very brief overview of some of the causes of hemolytic anemias. So your hemoglobinopathy, sickle cell disease, autosomal recessive disorder, the problem with your beta globin chains. There's a point mutation of glutamine to valine at position 6. And that basically means that your hemoglobin polymerizes and forms clumps at lower oxygen tensions. You get basically clumps of hemoglobin, which damages your endothelial lining of blood vessels, causes activation of coagulation cascades, and yeah, patients basically present with these sickle crises. HBS, so if you have one allele, you're a carrier. If you have two, you've got the disease. And it's relatively common in people of African and Southeast Asian descent because it confers resistance to malaria. So enzyme defects, G6P deficiency. So G6P is a key enzyme in the pentose phosphate pathway. Basically, you don't need to know that. You just the enzyme protects cells against oxidative stress. So these patients typically present with hemolytic crisis when exposed to large oxidative stress. So in medical school exam finals, the classic one is fava beans, if they've had like a bag of broad beans the night before, or in response to anti-malarial drugs or some antibiotics. It's an X-linked disorder, so mainly seen in men, and it's common in people of Mediterranean origin. And you classically on blood film get bite cells, so like someone's just taken a bite out the red blood cell, and these hind bodies, which I think is some derivative of hemoglobin, but don't quote me on that. Then moving on to your immune-mediated hemolytic anemias, you can split that into your warm immune-mediated hemolytic anemias and your cold type. In your warm type, you basically get IgG antibodies forming against your red blood cells. And in your cold type, you get IgM antibodies forming against your red blood cells. So if you go back to our case, his immunoglobulins were normal. And then with both warm and cold types, you can get this primary, so idiopathic, or secondary to something else. So in your warm type, you can get it secondary to a lymphoproliferative disorder, autoimmune disease, or drugs. And in your cold type, the classic one is secondary to like infectious causes, mycoplasma being a typical cause. And then you can get hemolytic anemias in response to drugs through this process called haptenization, which basically means a molecule will only trigger an immune response when bound to a larger molecule. So the drug on its own won't cause a response. It's only when it's bound to the red blood cell that it triggers the autoimmune system to react. And then you've got your ABO and rhesus incompatibility as well. So that's your transfusion reactions and hemolytic disease of the newborn, which is rhesus incompatibility. And then your non-immune causes, so you get physical destruction of your red blood cells, forming what Amina said. So you get these schistocytes on blood films. Hypersplenism, so when your spleen is ramping up in response to infection or chronic inflammation. And this process is called microangiopathic hemolytic anemia, which is a process, it's not a cause. And basically you get endothelial cell damage caused by fibrin and platelet deposition in your blood vessels due to a systemic inflammatory response. And then the fibrin mesh that forms shears off your red blood cells, forming schistocytes. And this can happen in a whole host of things such as TTP, DIC, HUS. There's many causes. And you can also get physical destruction of red blood cells with prosthetic heart valves as well. So just a quick mention on DIC, which is disseminated intravascular coagulation. And it's a severe consequence of a systemic inflammatory response. So it can occur in sepsis, major trauma and burns, or malignancy. And you basically end up in this really dire catch-22 situation where you've got pathological activation of all your clotting cascades. So you're forming loads of clots, but at the same time, you're depleting your blood of all your coagulation factors. So you get massive amounts of clotting and bleeding at the same time. And you can end up with AKI and multi-organ failure. So it's really bad. And also on bloods, you look for things like fibrinogen, which will be raised. So final slide, hope everyone's still awake. So coming back to our case, so we did our CT CAT, which was negative for anything, didn't show anything abnormal, and our ultrasound didn't show any gallstones. The plan was that we were going to do, because he had temperature spikes, so we were going to do blood cultures if he spiked a temperature again. We ordered a DAT, which I checked this morning was negative. We wanted to do a complete viral serology, including CMV and EBV. With CMV, we do IgG and IgN. We wanted to do an atypical bacterial screen as well. And we sent a blood film. And FYI, I don't know if it's the same for anyone at Mary's, but if you're at Charing Cross, you need to send the blood film, or not send it, but you need to specify for it to be sent to Hammersmith for it to be interpreted. I learned that yesterday. And then you can also do a blood electrophoresis to look for your hemoglobinopathies. So in terms of our management for this patient, he is otherwise very well. So hematology were happy to discharge him with follow-up. He was commenced on folic acid, 5 milligrams OD. Can anybody, if anyone is still awake and listening, does anyone want to tell me why we gave him folic acid? Pretty easy question. Yeah, exactly. And we don't really need to give support red blood cell production. Your folate stores need to be readily repleted more so than your B12 because you have a longer reserve of B12. And we also gave him TED stockings. So that is it from me.
So
Thank you everyone for listening. I will, if anyone wants to know, we can keep them updated as to what the cause is.
Yeah, so we don't know. Is this what? That's why this is current and live case.
Yeah.
Okay. And that bilirubin was really, really high though, 200, I must say.
Yeah, and it would. So I was going to say, if you go back to the differential at the beginning, what does everyone think it is? So I think probably, I mean, off the list I gave there, Gilbert's is most likely, but you wouldn't expect a bilirubin that high.
Well, he might have Gilbert's and something else.
Yeah.
Yeah, so he starts off with a bilirubin about 30, and that's really quite common.
Yeah.
And then you hemolyze on top of that. But why is what was the hemoglobin again?
1, 1, 2, 3.
Yeah, it's not really low, is it? To be if it's hemolyzing rapidly. And sorry, we don't know what's on the film because that will be quite useful.
No, we don't know what's on the film.
No? Okay.
Yeah, but it's interesting.
And Joe he's got a G6PD deficiency as well as being unwell. He could have G6PD and Gilbert's and be unwell. Can I ask about that Heinz baked beans there? Is that Heinz bodies?
That's for Heinz bodies, yeah.
I got confused when you said beans because, of course, you mean baked beans are safe, are they?
Baked beans are safe, I think.
I'm not sure. I think baked beans might be the same as fava beans.
Fava beans.
in terms of causing heat. I think it is. I think all beans. I think fava beans is just beans, as you've got a picture there, normal beans.
Oh, are they not broad beans? Oh, a big broad beans. I don't know enough about beans, to be honest.
Nor do I. Any beans experts in the room?
Has there been a TB screen?
Yeah, fava beans are called broad beans in the UK. Yeah.
I don't think we did a TB screen. What?
Okay, thank you. Baked are haricot, and therefore we can eat baked, can we? Okay. Tuberculosis screen. So
I don't know what we'd be looking for with the TB screen.
There's no options. He's not got a cough or sputum. You might do a Mantoux. Yeah, or IGRA. The film should come back quite quickly, though. You'd hope they'd look at the film and say, "This is what it looks like."
Yeah, I don't know. It could be back, but he's left, so we're not sure where he's gone. We'll have to find him on Cerner.
What, the patient's left? Yeah. Oh, left your ward, you mean? I see. Yeah, yeah. Oh, he's on 7 West. There we go.
Oh, thank you.
Okay, well, 7 West will tell us the answer one day, hopefully. Thank you. Yeah. That was really good coverage of a bit of hematology to remind us all, including me. So thank you for that. Anybody else got any questions or worries? Yeah, very interesting case. Yes, actually, so I'd like to know the answer next week. If you could tell us, have a quick shifty. We'll have a look, or you could email me the patient hospital number, and I'll tell everyone next week. Next week we've got an oncology case. So we'll see you all then. I'll send the details out as always on a Thursday or Friday, and see you then. And just before I forget, I've now got 3,000 signatures, so thank you for those of you who signed. On the email that tells you about today, there's a link if you've not yet done it, because we need 10,000, so we're a third of the way up. And if you click on map, you can see it's all this zone. It's all Hampstead and Fulham.
Sorry, I forgot to put your thing on the end.
Oh, that's all right. Oh, I can do that.
Cool.
Okay.
Thank you, everyone, for coming.
Yeah.
Thanks, Izzie. Good job.
There we go. Can you see that? 3,065 signatures. And if you click, this is a bit of fun. If you click show on map, you get a map of the UK. Then you can see in colour where the proportion of people who've done it are. And it looks like there's one area up in Scotland that's particularly popular. In fact, if you zoom into London, if I can do this now, I'll just move it up a bit. You can see that it's all us, actually. Click that one, bring it left. It's great fun, this. So we'll just zoom into London. Do you see? Can you see H&F yet? I'll bring it up into middle of the thing. So you can see it's definitely us, that dark blob. We're signing it. We need to get the rest of London on it, I think. Great. Okay, I think I finally got there. We're almost black there in terms of numbers. Yes, anyway, thank you all. So if you would like to all join us, that would be good. And then and then for some reason Harlow have 0 signatures. I've got to get Harlow on board. Okay, see you next week, guys. Thank you.
Thank you. Do you want to on or should I? Oh, how do I do?